Dr. Laura Porter is a stage 4 colon cancer survivor and has worked as a patient advocate and a medical advisor for nonprofit organizations for over 17 years. As a research advocate, she is a grant reviewer for several organizations and serves on several committees with ASCO. She is currently a co-investigator on an international grant through Cancer Research United Kingdom, Team Optimistic, which is studying the microbiome and the impact on the development and treatment of colorectal cancer.
Hello, thank you, Kim, for the wonderful introduction. And I'd like to welcome everybody to the first AllyCon Doctors Meet and Greet panel discussion. Today, I am joined by Dr. Cathy Eng, who is a medical oncologist at Vanderbilt Ingram Cancer Center and the David H. Johnson Chair in Surgical and Medical Oncology, and a professor of medicine, hematology, and oncology. I am also joined by Dr. Deborah Keller, who is a colorectal surgeon and a clinical assistant professor of surgery at University of California at Davis Medical Center. And also John Marshall is a medical oncologist at Lombardi Comprehensive Cancer Center, Georgetown University Medical Center, and the chief of hematology and oncology. And last but not least, Dr. Michael Pishvaian is a medical oncologist and the director of gastrointestinal developmental therapeutics and clinical research programs at Kimmel Cancer Center in the greater Washington, D.C. area. So with that, welcome everyone. We received several questions before that were solicited by the team prior to the conference. So I will be addressing some of the questions to the panel members. First of all, I'll start with Dr. Eng. So one of the questions was, why are so many early onset patients? Why are there so many now? Do you know why? And have they gotten closer to determining if this is environmental or what the cause may be?
I would say that probably there's increased recognition, excuse me, that this is a growing problem, in large part because of increased awareness and education, but in large part because of patient advocates. I think that many of us were seeing these young patients in our clinics for several years, but you know, in all fairness, many of us are in academic medicine, and so it's hard to say if we were having a very selective biased opinion, but the reality is that the numbers indicate that there is an expected rise over the next decade for left-sided colon and rectal carcinoma. Do we know exactly the exact etiology for this? No, I would say that is a big component of research for many of us because we obviously see many of these patients at a later stage, and so they really have a very significant impact when we start treatment on them, and we really want to be able to provide better options for them. So I would say that we don't have a definitive answer as to why these patients are being diagnosed and why there's an increased incidence. I would just say that thank you to patient advocates, as well as my colleagues that have also noticed the same thing in their practice, that now we're able to educate other individuals to be aware and to maybe recognize that screening at an earlier age is important.
Thank you. To just continue along those lines, also, I noticed this week there was a paper that you posted on sexuality and discussions with a doctor for young onset. So one of the questions we did receive was sexuality and cancer. Why do doctors not tell female radiation patients? Dr. Keller, this could be applicable to you too, about the side effects and the harm radiation does to the female genitalia and how to prevent permanent issues. This person said that she did not know she had to ask her doctor about it, that she feels that the doctor should be more forthcoming.
That's a great comment and a great question. And I completely understand, obviously, the the sense of maybe that she didn't feel that she was as informed as she could have been when she was initially diagnosed and initiated her treatment. I think that many of us obviously are recognizing that our young patients, once again, are specifically more likely to have this impact upon their quality of life with potential chronic toxicities. I would say that most of us do try our best to have that discussion with the patient, especially since it's a multidisciplinary discussion between the surgeon. I'm sure Deb's going to go into that as well, Dr. Keller. But, you know, and especially for our rectal cancer patients with the radiation oncologists, all treatment has some potential toxicities. And I think that has to be very clear. We obviously do our best to cure their patient of their cancer when possible. And it's sometimes, it may place the patient at risk for slightly increased toxicities. I would presume the patient signed an informed consent in order to undergo radiation therapy, but they shouldn't just rely on the fact that it's written on a piece of paper. It should be a point of discussion. And especially for our young female patients, I always discuss the fertility issue, but it's not just females, it's males as well, because we're talking about bowel dysfunction, potential urinary dysfunction, sexual dysfunction. So it's both sexes. So I think it's very, very important to keep in mind for both females, but as well as males in regards to potential sterility, and then for females for preservation. So I'm unfortunately, I'm sorry that this patient experienced this with their physician. I hope her outcome has been very good. But I think moving forward, I'm very glad that she brought up this discussion, because others will now learn that they should ask their treating physician and their team about those questions. And then I think it just increases awareness. I think we're very well versed on it, I would have to say, because I know most of my colleagues here on this call. It's just what we do. But I don't have a perfect answer for her as to why she didn't have the same experience and didn't feel as informed as she felt she should have been.
Thank you very much. Go ahead.
I quickly
Dr.
add in
Keller.
that as Dr. Eng and her colleagues are getting so much better at making cancer a curable disease, we're concentrating more on functional outcomes. And it is terrible, but a lot of surgeons don't ask about sexual function. And when they do ask, they ask men more than they ask women. And when we're talking about quality of life, sexual function absolutely has to be part of the conversation, as well as fertility. I mean, we can't move insurance companies to cover infertility treatments and freezing eggs and banking sperm until we have data to support it. But we don't do a good job at surgeons about asking for these issues and treating it postoperatively. So even postoperatively asking, are you having dyspareunia? Are you having pain with intercourse? Are you having stenosis? Do you need physical therapy? Do you need dilation? There are options for people because we want them to have their whole quality of life.
And Laura, I might pile on to say that some of our most important clinical trials that we're doing right now are looking at doing less. Can we get away in certain patients without radiation at all? How do we preserve anal function for not just sexual function, but your self-image and all of those things? So we finally gotten to a place where we're beginning to swing back from we have to do everything on the planet to try and cure you to now what's the best way to cure you and maintain your function at its fullest. So I think to our patients listening in, those clinical trials are going to be the current ones, and the ones of the future are going to help address this. So your voice has clearly been heard.
And
Thank
actually,
you.
just jumping on to John's, I mean, some of the new trials actually for rectal cancer, right, don't even include surgery now.
Right.
Yeah.
Everybody's out of it. We're going to try to put the surgeons out of business and the radiation out of the business, but we keep staying in business, right, Dr. Eng?
Unfortunately.
I was going to add one more. Yeah, I was going to add one more comment on as well, which is about being informed, not just as a patient, but as a patient caregiver. And there are so many patients that come into our office that just really are deer in the headlights. But if they have a partner or a friend or a family member there with them, they tend to absorb a lot more of the information than the patient necessarily does. So that's the importance of having somebody there with you really at every visit. And as coronavirus is sort of hopefully coming to an end, we'll be able to allow more of those patients to be in there with their caregiver in the room.
Thank you. So one of the, we have a few questions about rectal cancer. So one of the questions was about how rectal cancer patients are selected for short course radiation versus the standard 5-day, 5 weeks standard course. And I know that when I was on the NCI Rectal Anal Task Force, we looked at a number of different protocols on this topic. And Dr. Keller, would you like to address that? And then the rest can.
Sure.
Thank you.
And you do want all of the treatment decisions to entail the multidisciplinary care team and the patient. But short course radiotherapy, giving the entire dose over 5 days, is a valid strategy. There are multiple randomized control trials that support that patients receiving short course radiation have comparable or better local control, longer survival outcome durations, and significantly less radiation toxicity. And there's been a trend in the more recent trials towards fewer post-operative complications with short course when we're delaying surgery afterwards between 12 and 14 weeks to give the radiation more of a chance to work. So specifically for metastatic and locally advanced rectal cancer patients, there's considerable pathologic complete response rates, which can be used to initiate the watch and wait strategies or just make a tumor more amenable to resection. And it also opens a window of opportunity, bringing chemotherapy forward after radiation therapy and before surgery, the TNT strategies, which can also treat micromets. And it can also have better patient compliance because you're asking for 5 days instead of 28 to 31 days. There is some concern that it may be worse for the muscle, for the function after surgery, and for the connections that we make. So we do need more research, but it's a valid strategy.
Okay. Thank you. Anyone else want to comment on that?
I sometimes feel like we don't know the right answer to the question. We bring a lot of bias and hunch, and as Debbie was saying, there's data, but is one better than the other? Is radiation always required? These are the questions we're asking as these technologies are advancing and as new science is coming. So even within, just in full transparency, even within our own tumor boards, for example, when we are doing multidisciplinary decision making, we debate this among ourselves. And so we're in a place where we don't have an exact right answer. Yeah, we're the most experienced people on the planet doing this, but that doesn't mean we know exactly one is the right fit for one person or another. So we do try and use our best judgment with the person in front of us and the challenges, the side effects that we're trying to avoid, and make the best recommendation we can.
Thank you.
I'm sorry.
Go ahead.
I was going to add on to John's comment. I fully agree with him. I mean, we had a lot of data regarding rectal cancer over this past year, but one of the studies was a phase 2 study that was basically a single arm study compared to historical controls. And then we have a very interesting Prodige study, but that used full FASCRS, and it wasn't total neoadjuvant because it was only 3 months before going to surgery, and then 3 months of adjuvant chemotherapy. And then of course the repeater trial, which was a 5x5. So they were all very different studies. So that's why I understand exactly where John's comment is. It's we're learning more, and we'll probably continue to learn more, especially since we're talking about the consideration of non-operative management as well. And then we're waiting for the results of the prospect study, which is where they're considering omitting radiation. So there's a lot of moving parts.
Thank you.
People are very polarized on short course radiotherapy. There are centers where I've trained at that absolutely want to do it. I have mentors like Anna Martling that believe so strongly in it. At Sloan Kettering, they are so strongly against it. So, it depends on experience as well.
Very good. Thank you. So we have a couple of questions here that were regarding how a patient is chosen for different treatments. And I'm not sure that these can be answered. They don't need to be answered specifically, but what are the criteria that to choose whether the patient receives IR therapy or ablation, let's say for liver mets? And what's the difference between Proton and SBRT in terms of side effects and the effectiveness of treatment? So I know these are pretty specific, but I think that they kind of get at the whole liver mets situation.
So when I'm asked these questions, I do always consult a hepatobiliary surgeon, someone who deals with this every day. And again, we talk to the whole multidisciplinary team. But in a broad sense, we use the Barcelona Clinic liver cancer staging system and the treatment strategy, which incorporates the tumor burden, the liver function from a child's Pew class, and performance status so that you can define the prognosis and help guide your treatment decisions. So the treatment options for METs are stratified by the BCLC. Transplant, resection, and ablation are considered curative for very early and early stage disease in patients who are not surgical candidates. And very early is usually child Pew A liver function, in Eastern Cooperative Oncology Group performance status of 0, and a single lesion less than 2 centimeters. Early is going to be patients with child's class A to B function, ECOG performance status of 0, and a single lesion of up to 5 centimeters or 3 lesions each less than 3 centimeters each.
Yes. Thank
So
you.
use those as guidelines. And as far as Proton and SBRT, I'm naturally blonde. I'm a simple girl. I try to think of it as SBRT is traditional radiation. It delivers X-rays or beams of the photons to the tumor and beyond it. It's hard to control that and zero it in. So it can damage the nearby tissues because you're hitting your target and everything around it. And by contrast, proton therapy is going to be a more focused beam of particles that stops at the tumor. So it's more precise and less likely to damage healthy tissues that are around it. So you would think that this has fewer side effects than traditional radiation, since doctors can control it better.
Yeah, as the oldest member of this panel, I'm pretty sure, we have to reflect back that it used to be blasphemy to think about resecting or treating liver metastases directly.
Yes.
And so this whole field of what metastatectomy or managing regional disease was pioneered and championed by the colorectal cancer group. And now other disease areas are actually taking our lead on this. So we were number one on this one. And we figured out that we could cure some people with metastatic disease. Surgeons could cure some people with metastatic disease by removing the lesion. So the gold standard was surgical resection. Well, not everybody's tumor is in a place that can be surgically resected, or maybe there are other medical conditions that make it so that it's maybe too risky to do that. So these other technologies were developed like was said, ablation, where you like freeze it or heat it. That is close to equivalent to resection in terms of getting rid of that spot once and for all. But then it gets less and less what I call ablative to patients. It's kind of becomes more of a stun gun. So on the other end of the spectrum, our Y90s, our embolizations, our external beam radiation, whether it's proton or regular, become stun guns, sometimes get rid of for good, but we can't count on it. So when we pick and choose among the different technologies, sometimes those are the only ones in our hands for that particular patient, and we try to apply them accordingly. So this is possibly the most fun we have in our world, of getting a patient with a complex set of lesions in various places and using all of the tools that we have at our disposal to get patients to what we call no evidence of disease, in the hope that maybe, just maybe, it was the last weed in the yard and that we fixed them. But even if we know that's probably not the case, we'd rather them be no evidence of disease than having visible cancer. So we use all of these strategies to get us there.
And if you don't mind, I do want to just add one thing on Dr. Keller's comment. Not everyone has a proton beam center available to them. And so we also have to be very careful about suggesting that that may be the only entity. The majority of institutions have, stereotactic radiation therapy, et cetera. It's just proton beam centers are few and far between across the United States. And so it's actually only FDA approved, if I recall, still for prostate cancer. I think, I guess you could potentially get it for GI malignancies, just to keep that in mind. Stereotactic radiation therapy or Y90 or any of the other approaches, as long as you do it at a very at a center that you feel comfortable with, you should feel very confident with your outcomes in trying to, as John stated, make you NED, or no evident disease.
And I'll
oh, go ahead. I'm sorry.
Just going to add one other comment on it to reemphasize something Dr. Keller said, which is the idea of a multidisciplinary care, because overlapping with Dr. Eng's point also, not everybody has access to a multidisciplinary board, but it's really critical to be able to get multiple opinions from experts in the field. And if I go ask my interventional radiologist whether or not they can treat a spot, they will say yes, for sure. But to Dr. Marshall's point, I also need to ask the surgeon and make sure that the surgeon shouldn't get a first crack at removing the spot surgically. So having a group discussion, ideally all in one place, is the best way to approach these patients.
Thank you. Thank you. I want to circle back on something that was mentioned. This was ECOG status. I know that is a big term, and I learned about that in the last couple of years when I was trying to help people find clinical trials. And most of them were not well enough to get on clinical trials. So if you could just briefly touch on that. And tomorrow we're actually going to have one of the speakers is going to be talking on clinical trials tomorrow. So you all can tune in tomorrow for that. But just to touch on the ECOG status.
I'll quickly say on Monday morning, I'm an ECOG of 0. By Friday afternoon, I'm a good 2.5, just to let everybody know. Mike, you're probably the expert in this. Why don't you tell?
I don't know if that I am, because I'm definitely a bias when it comes to ECOG status, because I think ECOG is in the eye of the beholder many times, and especially with GI malignancies. And when a patient walks in untreated, their ECOG performance status may be worse, but that you can improve them with treatments and chemotherapy. So I think that in many ways, ECOG status is a little bit subjective. But to answer the question, to be a little bit more granular, ECOG status is really a measure of functionality, of how capable a patient is of completing their normal activities of daily living. And it's a scale that we follow. It has some guidance on that scale. And there are definitely data to suggest that poorer performance status patients do not do as well, do not benefit as much with different therapies, be it surgery, chemotherapy, or otherwise. But I don't, we're forced to follow these rules for a clinical trial, but at the same time, when it comes to sort of standard of care treatment, I think that these are very gray guidelines, they're very loose guidelines.
It also gives us a push as surgeons that may see a patient first to get them into prehabilitation programs and try to get them fit for treatment and fit for surgery.
Thank you. Yes, I think that that's an important thing. I try to stress to people that the best time to look for clinical trials is when you're diagnosed, because you're the healthiest and you at least have some in your arsenal if the standard of care doesn't work.
Yeah, Laura, I might add into Mike's point is that, to be in a clinical trial, you have to be in really very good shape. Your kidneys have to be in good shape. Your liver has to be in good shape. And so almost every patient, or lots of patients with cancer, are messier than that and have stuff that we have to then deal with. And our clinical trial data, therefore, reflects that sort of ideal patient. And then we have to extrapolate in real world to how we would apply that to patients. So, this is a fairly strong advocacy meeting as well. And so more pressure applied to clinical trial rules that allow for a broader inclusion could actually speed accrual, give us better real world evidence, and maybe in the end be better serving to the population at large. So that's just a little geopolitical comment from Washington.
Thank you very much. So the next set of questions basically are about biomarker testing and CEA. So we'll start with a general question. Somebody wrote, I'm newly diagnosed What are the best questions to ask my oncologist to help me understand my disease? The floor is open. John, you want to start?
Gosh, yeah, sure. I mean, there are some key elements that we can take a page from our breast cancer colleagues. Every breast cancer patient knows whether they're ER, PR, HER2, or triple negative, every single one of them. So in colorectal cancer, we have a similar list. Honestly, regardless of stage, you need to know what's called microsatellite instability or not. Not everybody has an inherited cancer syndrome that has this characteristic, but you need to know whether you have it or not. Not common, but you need to know. In the metastatic setting, the list is longer. You need to know of mutations called RAS and BRAF and HER2. In addition to MSI, in that list, thanks to work that Cathy and Mike are doing, is getting longer and longer. And so you need to know your molecular characteristics. You need to know your stage, how far along the tumor was, where it spread to. You need to know sort of the roadmap of where you are. And then each of those has its own branch points. So I think getting that first understanding of where you are, what your stage is, what your molecular types are pretty high on the sort of data points that I think you need to know as you start your journey.
And I would also add one thing, and I usually like to have this as part of my discussion with any new patient. Number one, as John mentioned, know your stage, but also know what the objectives of therapy are. You want to know, is this potentially resectable now? Is this potentially resectable maybe if the shrinks a little bit, and because we have a few sites of disease, and that's why we're going to a multidisciplinary tumor board? Or is this a case where there is no potential role for radiation or surgery because the disease is so diffuse and more widespread that chemotherapy is really our best option here? And then we're trying to focus on what's called palliative therapy, which really is meant to say that currently any type of intervention is not necessarily our first goal. Our first goal is chemotherapy. And as John mentioned, as personalized as much as possible based upon the molecular markers, but to improve the patient's overall survival with good quality of life, still maintaining good quality of life. So.
I'll add a couple of points on, and they'll be jumping around a little bit to try and adjust a few points. First of all, just to reemphasize Dr. Eng's point about quality of life, colorectal cancer patients who are diagnosed with advanced cancer that's widespread, that cannot be cured, and unfortunately we know that from the outset sometimes, the reality is that this is a disease that on average the survival for which is measured in years, not months. And so as Dr. Marshall has said many, many times, this is a marathon and not a sprint. And the idea really is to maintain as normal a functional quality of life as possible for as long as possible. And really that is on a foundation of chemotherapy, but can incorporate other modalities as well. So the term palliative care, while completely accurate, is also a terrible term because it's really like we want to have you living normally. And I always use the analogy of diabetes, where diabetes is a completely incurable disease, and yet people live with it for years and decades. And we're not quite there yet with colorectal cancer, but we certainly have improved more and more in just the time that I've been working on this. The other comment I would make about biomarkers specifically is that some of the biomarkers are starting to make their way into earlier stages of cancer. And in particular, this comment about microsatellite instability or MMR, mismatch repair presence, gene or protein presence, is important and really should be tested in every single patient, regardless of their stage of disease, and should not be guided by family history, because there's very good data to suggest that family history does not actually predict for whether or not these tumors have this uniqueness, this specific abnormality. And also we know that 10% of them are not, or half of them, we'll call it, are not genetic inheritance, or sort of born that way within the tumor itself.
Oh, go ahead, Deb. Sorry.
From a surgical standpoint, I think it's always important for people to tell the doctor what their personal goals are, and to ask, how long will it be until I can get back to this, until I can get back to work, until I can get back to living at home, whatever is the most important to them. And also, how much will this improve my survival? this either chemotherapy regimen or immunotherapy regimen. And something that patients ask a lot is, if I was your sister, if I was your mother, what would you do? That's a difficult question to answer. But if you ask your doctor to phrase it in what's a best case scenario, what's a worst case scenario, and what are my treatment options there, that can be effective.
We've been talking a lot, my wife and I wrote this book, and we came to realize that we as in the medical community, particularly oncology, put a lot of options out in front of patients and then step back and say, you pick. Well, that's really difficult. We put people in a very difficult situation. So I don't mind being pushed to, what would you do for you, or what would you do for, in your situation? But I like the way you put that about, here's what could happen if everything goes perfectly, and here's what could happen if it doesn't. One other molecular marker, the CEA, was mentioned in your question. Yeah, we still measure it. We are hopefully getting to a place where some of our blood testing might get even more precise. Everybody's talking about CTDNA and finding shreds of cancer cells or DNA in the circulation, and using that to say, yes, you still have cancer or you don't, or even following along in terms of, is your cancer treatment working or not? So CEA still, sadly, is our gold standard. It's still useful to us all, but we are hoping that newer technologies will move us to a next generation on that.
So, and also I think that one of the concerns of a lot of people is that CEA is not a marker for them.
Yeah.
So, I mean, for me, it was exquisitely perfect marker for me. I knew exactly when things were coming back. So, but I know that that's not the way it is for a lot of people. And
funny, Laura, it kind of changes for people too. Some people will have an elevated preoperative CEA, and then it's never elevated again, even when the cancer comes back. So as you say, it's not consistent for everybody, but it is useful for a high percentage of patients.
Thank you.
But your point is why we need to develop better ones.
So you brought up CTDNA, which was another one of my questions. I know from all of the meetings and things I've been to that CTDNA, last I read, it may have changed since then, but it's approved for early stage 2 and stage 3, I believe, along with a CEA to monitor for disease recurrence. But I think that one of the questions is stage 4. Do we see it coming into prime time for monitoring for stage 4? Not just recurrence, but also response to treatment, like you mentioned. So questions open.
I'll kick it off, but I'm sure everybody has maybe a slightly different opinion. I mean, I think I've been using it for stage 4 patients who have been resected as a measure, just like I would in stage 2 and stage 3 disease, to look for recurrent disease. The problem we all have with this test is we don't know what to do with it. All it right now tells us is that if it's positive, that you still have cancer somewhere, and we don't know exactly how to respond to that. It's knowing bad news earlier. And we hope that with this knowledge, we figure out what to do with it. And I will say that there are a few patients, just like we talked about before, those patients whose CEAs are not elevated, that I have used in a few cases this kind of testing to track them. But Mike's one of the world's experts in this field of molecular and precision medicine. Yes, you are. And I think my take on this is that everybody's going to be getting this kind of test routinely pretty soon. And it's not only going to tell us yes, no, but it's going to tell us what molecular markers we're actually tracking, because the audience needs to know that not all the tests are the same. So I'd love to hear the others comment on where they think this is going to go.
Yeah, I'll weigh in. Actually, I tend to be a little bit more conservative when it comes to ctDNA testing. So ctDNA testing, as Dr. Marshall said, tells us that there is likely the presence of cancer, and it definitely tells us the patient's prognosis. I am actually a little hesitant to use it for stage 2 and stage 3 patients because the prognostic value is so high, but we don't know if that's actually going to matter in terms of how we decide therapy. In other words, can we intervene on that? I don't know if a patient wants to know that they have positive ctDNA after surgery, because if I can't actually change their outcome with the chemotherapies that I choose, that may actually just be a black cloud hanging over their head. But I do think that the research is going in a direction, and certainly there are several critical studies that are going to give us this answer. It's just going to take a few years to know whether or not patients with a positive ctDNA, in other words, the presence of tumor DNA in the blood after surgery, if they are augmented to a higher level of chemotherapy or a higher chemotherapy plan, are they more likely to benefit from that versus the standard treatment? And the opposite being true as well. If they're ctDNA negative and you de-intensify chemotherapy, are you risking their outcomes overall? And then just one last comment about biomarkers and following ctDNA. I think one of the real values of following ctDNA in a stage 4 patient is not as much sort of knowing if they're going to recur earlier. That I think, again, the research is going in that direction, but also you have to not just look at the quantitative, the total amount of DNA, but actually what are specifically the mutations that are being identified. And there's some really nice work demonstrating that EGFR based treatment or cetuximab and panitumumab based treatment can be, you can recover that function based on the biomarker assessment in the blood, and mutations in BRAF and amplification of HER2. All of these things can be found in the blood test, not the quantitative ctDNA test, but the specific readout ctDNA testing.
I agree that it's important, but it's not something the treatment decision should be based on. We are more and more aware of the heterozygosity of the tumors themselves. And, I think it's a good marker to say something's wrong here. We have to look further. But I mean, as the surgeon of the panel, I'm the person for scoping and biopsying and actually looking at what we are, taking out and what's residual there in the bowel.
Yeah. Laura, I may loop us back to the beginning. I mean, we've now started, there's some patients with earlier rectal cancers where maybe a transanal approach was taken, or sort of alternative organ preservation approaches, that this kind of assay might, it's a big question mark, might help us inform who would then need to go on and have a curative, it needs the surgery as part of the curative therapy versus could be observed. So I'll stick to my guns and say I think this is an important new innovation that we need to figure out how to use. I completely agree with my colleagues on that. But that through sort of collaborative research and with our patients too, because as Mike says, this could just be nothing but early stress we can't do anything about. So anyway, I think it's here to stay, but we hopefully we'll figure out how best to apply it.
Thank you. I think that also, I think that's also important for folks to remember that, it's relatively new technology. And although we can see the results, we're not always sure what they mean as far as, so it looks like you're going to recur, but that doesn't mean you're going to respond to treatment either. So I think that, more work needs to be done, but it's definitely a step in the right direction. I think particularly for those who CEA is not a marker for, and some of the other things you all mentioned. So, and Dr. Eng had to leave. She had another engagement. Just wanted you all to know we didn't lose her in the process. So now I'd like to ask you all to each with the, I think we've got quite a few minutes left. We can, let's talk about what is the most exciting recent developments you've learned of in the colorectal cancer space. And we can just have a round robin discussion.
I'm happy to jump in there because actually it touches upon a point that I wanted to make that I think is important for patients to hear. We were talking about biomarker therapy and biomarker-based therapy, and I've got a couple of patients who are very, very focused on being treated based on their biomarker, or even many patients who are very focused on being treated with immunotherapy. But the reality is that immunotherapy doesn't work in the vast majority of our advanced colorectal cancer patients. And chemotherapy actually works really quite well in many of these patients in terms of controlling or even shrinking back their disease. So used carefully, I think chemotherapy is still a very, very valuable tool in colorectal cancer. What I think is the real sort of next step in colorectal cancer is trying to define what's going to work for those advanced cancer patients beyond chemotherapy. We have 2 FDA-approved oral therapies that work, okay, but they are approved. They were proven to help people live longer than doing nothing. But we definitely need to make advances in that space because there's many advanced colorectal cancer patients who are in need of additional treatment, whose disease has progressed on the standard therapies and are really doing quite well. We were talking about functional status, who look perfectly healthy, but all they have left for them in terms of their standard treatments are these 2 oral therapies, and they are prime candidates for clinical trials to try and push the envelope. And that is a space where we're doing a lot of immunotherapy-based trials to try and crack that glass ceiling to make immunotherapy work for those, roughly 95% of patients. And there's some really, really scientifically well-designed strategies to try and achieve that, but we really haven't broken that glass ceiling yet. There's cracks, but we haven't broken through yet.
Thank you. Dr. Keller?
So I can't compete with my colleagues here for what they're doing to optimize our patients before and after surgery. But when we're in the operating room, something that I think is extremely exciting is the move towards precision surgery. And we've been using fluorescence imaging to help guide us. And here with some of the biomedical engineers, we've actually developed a fluorescent lifetime imaging model for cancer patients that works with the patient's own tissues and can actually tell us the amount of dysplasia and cancer and if it's present or not in the tissue. And we did our first human trial today, which was very exciting and promising. And then for after surgery, we're working a lot with low anterior resection syndrome. We're getting better and better at taking out lower tumors and putting patients back together. But again, that quality of life is so important, and using sacral neuromodulation to help with function and pain after surgery is becoming promising.
So could you just expound a little bit on the LAR, the surgery? Because another question that came in, I was going to save till tomorrow, but since you brought it up, so what can be done as far as, can they change their diet? This person said that their LAR symptoms come and go intermittently. So, and if you could explain briefly what the LAR is, and then we'll get back to you, John, and the other question.
I'll try to do this quickly.
Thank you, Dr. Keller.
And LAR is a low anterior resection. So it's basically a resection where you're taking out all or part of the rectum. And the rectum is literally a reservoir to hold stool, to tell the muscles of the anus and the pelvic floor to either clench or release. So when you're taking that out or reconfiguring it, you can imagine that you're going to have a whole constellation of symptoms from pain, fecal incontinence, constipation, problems evacuating, feeling residual volume there. It's a whole constellation of symptoms, urgency that really impact people's quality of life. And, again, as we're getting better and better about doing lower surgery, patients are having more low anterior resection syndrome. So we're trying to find ways of managing it better. And it is a whole pathway that we're trying to develop, from diet, medication, over-the-counter medications to slow transit, to help transit, to bulk the stool, to irrigation to help empty so that you can at least start your day and not worry about soiling or not being empty, to antidepressants for pain, pelvic floor physiotherapy for strengthening and helping recoordinate your function. And for patients that are recalcitrant now, we are working with sacral neuromodulation Bowel Cancer UK has a trial of ours that's sitting on their desk, and hopefully that'll get funded and we can move it over here, because in the patients that we are doing this on, they're getting at least 50% or more benefit.
Oh, that's very good news. Thank you. Dr. Marshall?
Yeah, Laura, this is preaching to the choir, but this is a cancer that can be screened and prevented. And, you know, we should be, I don't know, we need to get people screened. Now, I realize why we don't. Not everybody can take what turns out to be 2 days off work, or, you know, to get screened, but even the stool testing that's out there is better than nothing. And the hope is that one day we will have blood testing that makes this easier, because even our current screening doesn't solve the problem of young people with colorectal cancer and the like. So we need to, I'm excited about the re-emphasis around screening and early detection and prevention. So you don't want to ever be any of our patient is the real answer. Maybe Dr. Keller, she'll fix you. The rest of us, we're there to clean up. So if you need it. So that's one thing. But the second that I'm most excited about is honestly something we're also afraid of at the same time, and that's big data. I do think that we are increasingly making large data sets of colorectal cancer patients, their molecular profiles, their clinical outcomes, their treatments that we gave. And just like this thing knows everything I do all day long, you know, we'll be able to then apply this to make us more efficient, whether that's decision making on yes or no on treatment, what treatment, other new targeted therapies that emerge. So I'm optimistic that as we gather these huge data sets in the medical field, that we will learn from them. And then I want to give one shout out, because I know there's been a lot of talk about clinical trials and the work that we've been doing. The last year and a half, 2 years, has been very hard at every one of our shops, because we had to stay open. Cancer had to keep going in the face of the pandemic. And so we are also suffering from what we're calling the Great Retirement. And so many of our staff and our team members have quit. So the cancer care that's being provided across the country right now, I don't know of a center that's not short-staffed in some way, whether that's on the research team or the clinical care team. So we appreciate your grace and forgiveness as we try and continue to provide everything. But it has been a little bit of a slowdown on research, not on the discovery side, but on participation in trials. So we're hoping that we'll really see a nice increase in the year ahead and leverage some of these discoveries that Mike and others have talked about, and show that they are of benefit to our patients.
Thank you. So did you have something else, Dr. Pishvaian?
Yeah, I thought Dr. Marshall was going to, that was a very nice shout out, a very appropriate shout out, but I thought he was going to give a shout out to our friend and colleague, Dr. Weinberg, and others who are working in the field of the microflora of colorectal cancer. Why am I forgetting the word right now?
Microbiome.
Microbiome, thank you. Of the bacterial microbiome, which is of incredible significance, and we're really just scratching the surface of what we can learn from this area. And some of the work being done, not just understanding how the microbiome affects the risk of colon cancer, the predictive value of response to therapy, and actually some of the most exciting areas is the potential for altering the microbiome, things like stool transplants that might render a patient's tumor responsive to chemotherapy or even responsive to immunotherapy, I think is really, really remarkable. And, you know, going to be a very exciting area of research in the next 5 to 10 years.
Thank you. Yes, I'm actually one of the co-investigators on a very large Cancer Research UK grant on the microbiome in colorectal cancer, headed by the folks up at Dana-Farber. And so I'm excited about that area too. So one of the questions that we received and is of interest to a lot of us, can you speak a little bit each of you on survivorship planning. For example, I know that when I was 5 years post-diagnosis, there were no guidelines because I was stage 4. So it has improved in the last 13 years, but still it's kind of, you know, what do we need to know? And also, if you're metastatic, and you're NED, how long do you need to be followed? I know I saw Dr. Marshall myself, and he told me when I felt like I could get a CT scan, and I appreciate that and haven't needed to. But, you know, because there really aren't any guidelines. And so, you know, who is to look after us? Is it our primary care physician, who a lot of times they don't want to be responsible for that? Or is it oncologist? Or is there a cancer support clinic or something like that? So
I'll give it a crack. I mean, first off, primary care doctors are a dwindling breed. There aren't enough to go around for anybody, and that old model of, you know, your family doctor for the rest of your life is sort of slowly being replaced by the doc in the box up at the local strip mall for urgent care. And so, you know, and primary care doctors are busy and don't feel like they have a lot of expertise. So that's why for some of them, they feel uncomfortable. On the flip side, oncology teams love seeing long-term follow-up patients. We do have some training in this area, but there's increasing pressure on us to utilize our skill set for the acute care of cancer patients. And so there is a tug and pull. Now, there are increasingly survivorship clinics. This is a good problem to have. Let's start here. So we have more and more people who are cured of their disease. In the old days, we just were delighted you hadn't died and didn't care what it took to get there. Now we're recognizing that not only are we glad you didn't die, we care about what we left you with. What divots did we leave? So that's, to me, the survivorship piece of this. So there are survivorship clinics you can go to that get either one-offs or continuity clinics. There are some guidelines, but when you get past 5 years, the reason there are no guidelines for any of these is that nobody knows, and you know, so there's no official study, which is maybe good because it's not that big of a. Maybe I'm going to say that wrong. It's not. We're unsure what the unmet need is, really. Is maybe a better way to put it. You know, I do think cancer generally falls to the oncology team to make the referral to survivorship, and generally is a requirement in most cancer centers that be done. How that's done varies by where you are in the country and what center you have. So let me shut up before I get in any more trouble and let some of the others chime in.
I'm happy to chime in here. I agree with the idea that it is a problem that we're very happy to have, of how to deal with more and more patients that are cured. I think one of the models that a lot of our institutions are trying to follow is the idea of not having to see a medical oncologist who, you know, is used to giving chemotherapy, but just following a oncology specialist, either a physician who is focused on that, or even a nurse practitioner or physician's assistant who can really help just follow a patient long term, because there are definitely needs that patients have, especially as younger colon cancer patients are diagnosed and perhaps treated with radiation therapy. We have to be concerned about things like secondary cancers 15, 20 years later that somebody needs to keep an eye out for, and that the primary care doctors might not be as attuned to. So I think survivorship clinics are good. They're not going to necessarily follow the traditional model of make an appointment and see your oncologist in 6 months or a year. But again, that is a good problem to have.
And I think the NHS actually does this better than us, because they have the cancer nurses that help coordinate not only the tumor boards, but track and maintain and see patients. And survivorship is something that's evolving, especially as we're doing watch and wait protocols, which don't follow any of our NCCN guidelines or other guidelines for how long do you see a patient. But you don't want to lose track of patients and have them come back with incurable disease because you don't know how long to follow them. So, all of the NCI centers and centers that are getting accredited need to have a cancer navigator. And this could be a critical role for the cancer navigator. It's usually a nurse or a nurse practitioner.
And I might add too that, when does survivorship start? Well, some argue that it starts the day you get your diagnosis, regardless of your stage, and that there's an element of survivorship even for patients with metastatic disease that we need to address and embrace. Just an aside, something that always bugs me, and I suspect there are both cured patients on the line as well as not cured patients and caregivers representing patients. But I was down making my morning rounds just to make sure all the lights were on in the joint, which Mike will remember, not always true. They were, which is good. But I was down there and somebody rang the bell. And then there was a cheer. Well, down in the infusion unit, that means somebody's finished their chemo. And I think we have to see this for the bittersweet moment that it is, because probably over half of the people in that unit who heard that bell and heard those cheers will never get to ring that bell. So the same is true for survivorship. I think we need to bring the same resources for those people who never get to ring the bell for them as well.
Thank you. I think that's an incredibly important point. Thank you very much. I know that, some of us are the fortunate ones, for sure. Also, I think another issue, and I, some of these are ones that affected me also, is that I know while I was receiving treatment, and I was diagnosed in 2003, and my last recurrence was in 2006. And while I was involved in treatment and everything, and then when it stopped, it was like, oh God, I'm just sitting here waiting for it to come back, like a sitting duck. But one of the things that I also didn't do, and I find that a lot of people don't do that, is get regular screenings for other cancers. It's like, oh no, I had colon cancer, that's enough for me. Well, that would be great if we could say that and it was true. So what are your recommendations for encouraging folks to continue with regular screenings?
Do it.
Well, that's
Definitely
easy.
do it. Yeah, I mean, cancer patients are at higher risk of having other cancers, significantly higher risk. And so screening becomes all the more important for them. And then to get back to discussion about genetics, 30% of colorectal cancer is familial or has some familial component to it, but we only know about 5 to 7% of the genes of patients for whom we can identify the genes that have led to that cancer. That means there's 20-25% of patients probably that have some genetic component. We just don't know what it is and what to test for. So having an awareness of that and being ready to screen for other cancers, and even being able to, I always make it a point for my colon cancer patients to always have a discussion about family members and the need to do a screening colonoscopy 10 years before the age at which the patient was diagnosed, and that the interval for screening colonoscopies for family members should be no more than 5 years, no matter what the results of the colonoscopy. All of these are important factors to take into consideration, for survivorship, and also for sort of understanding what to do with the patient with their cancer.
Thank
That's
you.
one benefit of the electronic medical record, that it will actually pop up for that patient if they haven't had one of the screenings. It's routinely recommended. But, we do have to be cognizant that there are shorter intervals for many of the other cancers. And again, a job that a cancer navigator could help with tremendously. Thank
you. One other thing. Oh, shoot. Did I forget it? Sorry, I was doing so good. Oh, yes. As far as the genetics are concerned, I know that I was diagnosed at 43. So at 33, my siblings were to get scoped. Now they didn't all, but that's ideal world. But I've just read recently that even cousins, so third degree relatives, not just first degree relatives, but second and third degree relatives. What do you all know about that? I know we only have less than a minute, so sorry. Is that news to everybody?
It's different from the guidelines that we normally use.
So, and the guidelines are basically first degree relatives 10 years or the age of 40.
But if there's concern, they can do something as simple as a Q-fit test instead of a full scope.
Okie doke. Thank you. Oh, so we have a few seconds left. I want to thank everybody for this this meeting and for being on the panel. And I hope that we have answered as many questions as we did at this time. So thank you all very much.
Thank you.
Thanks so much.